On behalf of Boulder Community Health, it is my pleasure to introduce this evening's speaker, Dr. Yerrapragada. Dr. Yerrapragada is a fellowship-trained orthopedic foot and ankle surgeon. Having completed extensive training in foot and ankle surgery, he's highly skilled in treating a broad range of conditions of the toes, foot, heel, ankle, and lower leg. He specializes in total ankle replacement, arthritis care, ankle arthroscopy, sports injuries, flat foot, Achilles tendon reconstruction, bunion and hammer toe surgery, cartilage injury and repair, and fracture care. He uses the most modern methods of treatment and minimally invasive surgery to help get patients back on their feet. He sees patients at Boulder Center for Orthopedics and Spine in Boulder and Lafayette, and Yuma District Hospitals and Clinics in Yuma, Colorado. Please help me welcome, and we're so excited to have Dr. Yerrapragada.
Thank you for the introduction, Wendy. I want to thank everyone for taking time out of their day to listen to me speak. And I'll be going over common conditions in the foot and ankle and how to treat them and what you might do to get over them. So I want to tell you a little bit about myself. I'm new to the Boulder area, and my training has taken me all over the country. I grew up in Texas originally, went to medical school in Kentucky. I did the bulk of my orthopedic surgery training at University of Washington in Seattle, and I did an extra year of foot and ankle surgery specifically in Baltimore, Maryland. As Wendy went over, I take care of all things foot and ankle, and even lower extremity fractures and other conditions. I see and manage and take care of my patients with that. When I'm not operating, I enjoy spending time in the mountains, snowboarding, hiking, and spending time with my family, my wife and 2 young boys when we get a chance. So the overview of my talk, I'm going to kind of give you a bird's eye view of foot and ankle. And there's a lot of conditions that affect the foot and ankle. I'm just going to go over some of the common ones. I'll start by just briefly touching on the anatomy, going over common conditions. Then spend a good portion of my talk talking about non-surgical treatments, because that's what the bulk of patients need, is non-surgical treatments. And the occasional patient that non-surgical treatment fails, we'll talk about operative treatments and getting them fixed. So starting with the anatomy of the foot and ankle, it's very, very complex. And I could spend a whole hour talking to you about foot and ankle anatomy, but I'm just going to touch on some of the things that make it complex. There's at least 30 bones in the foot and ankle, and the reason I say at least is a lot of people have extra bones in their foot that they don't know about until they come see me. But all these bones interact and articulate, and there's over 33 of these joints or articulations with these bones interacting. With those articulations, there's over 100 different muscles, tendons, ligaments, soft tissue connections, and they all work together in harmony to let you get up and move around and do all the things you want to do. So, to say the least, it's a very complex group of structures keeping you up on your feet. Next, I'll go over a few common conditions. Again, this is a very bird's eye view, talking briefly about each thing, but I just want to give everyone an idea of if you have an ailing foot or an ailing ankle, what may be the cause of it, and go from there. One of the most common things I see is arthritis. So what is arthritis, people may ask? It's pain and inflammation of the joints, and it's caused by cartilage thinning and degeneration over time. As you see on this x-ray on the right, the left image shows a nice pristine ankle joint, and where my cursor is demonstrates the joint space that's present. And alternatively, on the right side, you can see how this patient on the right has completely eroded their joint space. And that's what arthritis looks like in the ankle, and you can get arthritis anywhere throughout the foot or ankle. It's multiple causes, but the most common is age-related wear and tear over time. Other causes could be autoimmune conditions, infections, sustaining a fracture or trauma, but arthritis is a common condition that affects a lot of folks. What does arthritis feel like? It's usually waxing and waning pain. People say some days are better than others, and pain is often worse with increased activity. And typically resting, taking it easy, helps relieve the symptoms. The symptoms often respond to anti-inflammatories, as arthritis is inflammation. So something like an ibuprofen, naproxen, these anti-inflammatories typically help. And there's often swelling around the affected joint. It's the joints that are affected, typically tender to touch, that's the inflammation. And like I said before, it can be anywhere throughout the foot and ankle. So it's not exclusively one spot, it can really be any part of the foot or the ankle. Next, I'll moving on to tendonitis. And this is similar to arthritis, and that's inflammation, but not of the joints, of the tendons. Common locations are listed here, first one being peroneal tendonitis. These are tendons that live on the outside or lateral side of your ankle. They run behind the fibula bone on the outside of your ankle and go down to the middle of your foot. So if you're having activity-related pain on the outside of your foot or ankle, could potentially be tendonitis. Similarly, on the other side of your ankle is a tendon called the posterior tibial tendon, and this too can get inflamed. And what this tendon does is inverts your foot and also provides support to the arch of your foot. So tendonitis on the inside of your ankle could very likely be posterior tibial tendonitis. And another common thing that I see is Achilles tendonitis, and that's in the back of your foot and your ankle. So the Achilles tendon is the largest tendon below your knee. It's one of the strongest tendons in your body, and it attaches to your heel in the back of your ankle and foot, and oftentimes can get inflamed and very, very painful. So just like arthritis, tendonitis is an overuse-related condition. It's often activity-related pain that improves with rest and is associated with swelling over the affected tendon. Just like arthritis, this is degeneration over time and very much so activity-related. What's unique about tendonitis, or different from arthritis, is that additionally with the inflammation that you see, you may have some underlying partial tearing of the tendon, and it often responds to anti-inflammatories as well. Something similar to tendonitis is plantar fasciitis, and it's one of the most common things that I see in my clinic and one of the most common things that affect people. The plantar fascia is a thick band of tissue supporting the arch of your foot on the bottom of your foot. It's not quite a tendon, as it doesn't connect muscle to bone, but it connects bone to bone, and it's similar in its symptomatology in that repetitive overuse can cause micro tears, which result in inflammation, and again, it's very common. And as you see in that picture here, it's oftentimes affects the plantar heel where the patient has their two thumbs. Like I said, pain is usually in the plantar heel, but it can also be in the arch of the foot on the bottom of the foot as well. Pain is often worst in the mornings or after prolonged sitting. If you imagine when you're sleeping and sitting, your foot is in a relaxed position, your calf does get tight. So with the first steps you take, the calf stretches, cause a lot of pain and inflammation, and that's what people feel on the bottom of their foot. They often complain also of pain with prolonged ambulation as well. Risk factors for this is obesity. The more body weight we carry, the more stress across our ligaments, tendons, soft tissue, joints. And like I mentioned before, calf tightness can predispose you to developing plantar fasciitis. And I'll talk to you more later on in the lecture about the importance of stretching your calf. And again, endurance activities, dancing, running, repetitive overuse is a common cause of this, and especially living in Boulder, it's a common activity that a lot of folks around here do. Now I'm going to switch from some of the more degenerative overuse conditions to more mechanical conditions, and one of the most common things I see in the foot and the ankle are bunions. And bunions are a lateral deviation of the big toe. As you can see, the big toe on both these feet are pushing onto the lesser toes, causing them to sweep over laterally, and you get this big bump on the inside of your foot just below your big toe right here. That prominence is what's commonly referred to as a bunion. Bunions are most common in women. And the risk factors for this are narrow-toed shoe wear, high heels, and interestingly enough, genetic predisposition. About 70% of cases of bunions can be traced to inheritance of specific genes or factors from other people within their family. This is an x-ray of a patient with bilateral bunions, and you can see how the bunions are not necessarily a growth of the bone, that's actually a deviation of the bone. The first metatarsal here with my cursor tends to drift inwardly, and over time, because of the tendons of your foot, your big toe drifts the opposite direction. So it's a mechanical deviation of your anatomy that results in the bunion. Pain is over that bump on the medial part of your foot, and it's worse with narrow shoes, as you imagine. Shoes with narrow toe boxes cause pressure and impingement over that bunion, giving you pain. And if it's really severe, the big toe can actually cross underneath the second toe, which results in a hammer toe deformity of the second and sometimes even the third toe, as the second and third toes get stuck up as the big toe crosses underneath it. Almost always the bunion deformity progresses over time, and while there's some treatments to help with the symptoms, usually it tends to progress over time. It's different for everyone how quickly it progresses, but typically does. Another mechanical related condition I see often are stress fractures. And stress fractures are overuse related fractures. Repetitive trauma results in development of a fracture. It's not obviously apparent on x-ray sometimes, but it's there. And it can be anywhere in the foot. One common location are the metatarsals, as in this picture here, in the front of your foot just below your toes. But you can also get it in your calcaneus, which is your heel bone, your fibula, which is your ankle. And risk factors for this, one of the big ones I see is low vitamin D. With our North American diet and our latitude, especially in the wintertime, we typically have either low vitamin D or low normal vitamin D. And vitamin D, calcium are the building blocks of bone. And if you're deficient in one, you have a risk of injuring the bone and developing a stress fracture. Like I mentioned, poor nutrition, essentially getting low vitamin D, calcium in your diet can predispose you. And repetitive high impact activity also can get you to the point where your bone takes extra load and stress and it develops into a fracture. Like I said before, x-rays are often normal, but with serial x-rays, the way you diagnose a stress fracture is you see clouds of bone forming, which is bony callus, your body's response to healing. And if you see that, that's a sign of having a stress fracture that was not previously apparent before. As you might imagine, stress fractures are painful. And the subtle difference here is that you can usually localize it to one focal spot of pain. That's where the fracture is. With the more degenerative inflammatory conditions, it's more of a diffuse pain in multiple spots. But stress fractures, you can pinpoint usually one spot that hurts the most. Pain is worse with activity and weight bearing, and better with rest. And as you might imagine, it's associated with swelling as well. Another common injury I see, especially in the active population, are ankle sprains. And ankle sprains are the most common reason for missed athletic participation across the board. And it typically results from an inversion injury, as you see here in this picture. Sprains are on a spectrum, and that's something I tell my patients. And you can have a mild sprain, you get over it in a day or two, or you can have a severe one, it takes weeks, potentially months to get over. And it all depends on the force, the position of your ankle when it happened, and the degree of the injury sustained. You find bruising, swelling, that's from bleeding of the soft tissues. And just like anything, blood follows gravity, so your heel, your toes, the bottom of your foot is typically where you tend to see the bruising. And it's a lot of pain. It's often on the outside of your ankle or the lateral side. You may or may not be able to bear weight, and it can often mimic a fracture. So if you're having pain, unable to bear weight, when in doubt, I'd recommend getting an x-ray just to be safe. And pivoting from ankle sprains, you can have a little bit more trauma and results in a fracture. It can be even with minimal energy. There's a lot of people walking around who think they just bruised their foot or their ankle, and they get an x-ray, and lo and behold, they've broke it. So it can involve any bone, the foot and ankle, and you can see different pictures here of ankle fracture on the left, in the middle, a Jones fracture or a fracture of the fifth metatarsal, and on the right, a calcaneus fracture or heel bone fracture. So it can be anywhere. Just like with most things, you get severe swelling and bruising and pain, and the pain is pretty intense typically. You're usually unable to bear weight, but just because you bear weight and able to walk around does not mean you didn't break it. So again, when in doubt, I'd recommend getting an x-ray. And depending on the fracture, the displacement, the location of the fracture, you can get away with non-operative treatment for a lot of these, but sometimes it's an unstable injury that you need a surgery to get it fixed and get you back to where you want to be. So those are some of the common conditions I see. Next, I'm going to pivot to treatment, and I'm going to start with non-surgical treatment, as this is the bulk of what I recommend to people initially. So there's a wide variety of things you can try to do on your own or with the help of your provider to get over these conditions, and I'll start to kind of go over some of them. First line treatment for anything is RICE, the adage of rest, ice, compression, and elevation. That's the mainstay of most things, and I'd encourage you to, when in doubt, if you have an injury or even just develop pain and symptoms, start with this. Most conditions that I talked about are from overuse. So someone in particular this area, very active, participating in a lot of different endurance activities, they develop either an arthritis flare or tendonitis, but you think that you want to push through it, stay active, remaining active is overall good for your health. Not always. And in general, rest is usually the first thing that I suggest. If you're doing something that hurts, stop doing that thing. Ice can also help too. And in general, in the acute inflammatory phase, ice is often more beneficial than heat in terms of reducing the inflammation and the swelling. Compression helps as well, particularly with the swelling. And elevation also does too. As you might imagine, keeping it elevated, gravity brings the fluid out of wherever your affected injury is and helps with the pain. That throbbing pain you feel is from the swelling. And a key point is when you're elevating, as much as you can, keep it elevated above the level of the heart. If you think of your heart as a big pump of blood, but of just fluid in general, that in order to fight the strength of that pump and your blood pressure, you want to use gravity to your help. So as long as you have your affected extremity above the level of the heart, gravity will overcome that force and really help with the swelling. Another mainstay of treatment is anti-inflammatories. Essentially all the conditions I talked about has some element of inflammation associated with it. So anti-inflammatories and taking that is critical for pain relief and helps with the swelling as well. The mainstay of that are NSAIDs, or non-steroidal anti-inflammatory drugs. And the ones I typically recommend are over-the-counter. Advil, which is ibuprofen, Aleve, which is naproxen. But in some patients, taking the oral NSAIDs can cause GI upset. They can be toxic to your stomach, cause ulcerations. Not in everyone, but in some people who are more prone or predisposed to it. So topical versions exist, and relatively recently, the FDA approved some over-the-counter anti-inflammatory drugs. Voltaren is the brand name, but the generic is diclofenac, and it's a cream that is absorbed through the skin. And in particular, foot and ankle, we don't have much meat or skin between us and the bones and the joints and the tendons. So typically, Voltaren gel works well for foot and ankle conditions. And for those patients who have stomach issues, GI issues, can't take NSAIDs for other reasons, this is a good alternative that typically helps. And what's key is that for the more degenerative inflammatory conditions, I recommend taking 3 weeks of continuous NSAIDs of some kind to really make sure you can drive that inflammation down. If you take one every once in a while, you don't have a steady state of anti-inflammatory within your body. So taking a continuous course of that, 3 weeks is usually what I recommend. That can really help calm down inflammation wherever you're having it. Another important thing, of managing foot and ankle care, especially in the setting of acute injury, is immobilization. It's helpful in the initial stages, and you don't necessarily have to have an acute injury for me or someone else or for you to consider trying this. And that's because the boot, cast, brace, something like that, what it does is it stabilizes the foot and ankle and allow for healing to occur. When you have inflammation or an injury, trying to be active on it is probably aggravating it some more. You want to give your body an environment and something that it can reliably keep in a good position to allow for healing to occur, at least in the beginning. And that's what something like a cast, a boot, or a brace can provide. It results in stiffness, which is by design because we want to keep you immobile for a short period of time to let healing occur, and then afterwards we build you back up. And it often does help pain significantly. The type of immobilization depends on the severity of the condition. On the previous slide I mentioned cast, but nowadays I typically am not casting anyone unless you're a child. And the reason is most conditions you can get away with weight bearing, and a cast or a splint is difficult to bear weight because of the shape of the cast. And the nice thing about boots and braces is that you can take them off and you can shower and you can do normal hygiene and not have to worry about dealing with the smelly cast. But in general, you start from the more rigid immobilization and you transition into lower forms of immobilization as your symptoms improve. Depending on how severe your condition is or the type of condition, I may recommend a boot. But if your symptoms are more mild to moderate, we may start with a brace, which you can wear with regular shoes. On the far right is a post-op shoe. It's essentially a stiff sandal, and that's utilized more for toe conditions, where you don't need to immobilize the ankle or support the ankle, but you need a rigid platform to walk on for your toes, and that's what that shoe on the far right is. In general, Once you've gotten through the phase of boot immobilization or a brace or a post-op shoe, you want to think about what kind of shoes you're wearing regularly. And in general, supportive shoes are good overall for foot and ankle hygiene. Even if you don't have any symptoms, they're also really good for preventative measures as well. What I suggest is the thicker the sole, the more support that the shoe gives. So it cushions the foot really well with a thick sole. You can see on the far right, both options here, one's a Hoka brand, one's a Brooks brand, but you can see the common factors that they have really thick soles, and what that implies or what that suggests is that there's a lot of cushion in there to provide support for you. Similar to that concept, what I suggest and recommend for someone who has foot and ankle problems are to try or to have shoes that are relatively rigid, less flexible. And the less flexibility a shoe has, the better, because if a shoe is really flexible and bendy, what happens is your toes and your muscles and your joints are all moving more in a flexible shoe than in a rigid shoe. And with someone with either arthritis or other inflammatory condition, that causes more pain. So a rigid shoe has less motion across your bones and joints, which in turn provides more pain relief. One thing to consider in terms of shoes is looking at wide toe box shoes, particularly for patients with bunions, because the narrower the shoe, the more encroachment on the bunion accelerates progression. So what patients typically end up doing is getting wider toed shoes to accommodate their bunions. And like I said before, in general, it's a preventative measure too. If you're having no pain at all, no symptoms, I suggest considering these shoes. Another point or another part of good foot hygiene is orthotics. And what they do is they provide support and cushion for the foot. And for most people, over-the-counter versions work well. Unless you have a very unique foot shape or severe pathology, then I may suggest some custom orthotics. But for the most part, over-the-counter orthotics work well. And you can get these at a lot of different stores. You can get these at some pharmacies, at running shoe stores. And what I suggest is to try different styles and see what works best for your foot. Unless we're working on correcting a deformity in particular, in general, what I recommend is trying a bunch and see what fits well for you and works well for you, as there's many different types that exist. Here's some additional equipment, again, depending on the condition you have, that I may suggest that you get, or you may get on your own. The first thing is heel cups in the bottom left, and these are specifically for plantar fasciitis. So when you have pain around the heel on the bottom of your foot, these cushioned heel cups, something you can slip into your shoe, you can get that in most places, and they just provide some extra support for your heel right where that inflamed plantar fascia is. In the middle is what's called a night splint. And if you remember taking a step back, plantar fasciitis, people can be predisposed to developing that if they have a really tight calf muscle. So what this night splint does is you wear it at night while you're sleeping, and it actually keeps your ankle at 90 degrees, which is stretching your calf muscle. So by stretching your calf muscle overnight while you're sleeping, that first step when you wake up, you don't feel that big tug of your calf, resulting in big pain in your plantar fascia. This helps alleviate that, and one of the mainstays of treatment. Metatarsal pads are in the top right corner, and those are pads that here it shows sticking on your foot, but you can also stick that into your shoe. But they're adhesive. They provide a little bit of a bump when you take a step, and when you take a step, it elevates your toes in front of the pad, which offloads your toes. So for conditions of the toes, such as Morton's neuroma or what we call metatarsalgia, other lesser known conditions of the toes, I may suggest this, and what it does is offloads the front of your foot. And lastly, in the bottom right, is an example of a toe spacer, which is something that you can try for bunions. And for people whose bunions are starting to push over onto the second toe, causing pain and irritation in the second toe, you can try these silicone toe spacers to spread them apart, provide some symptom relief. It doesn't necessarily stop the progression of the deformity, but it provides some symptom relief. And it's something you can consider, especially in the early stages. Last, but certainly not least, one of the most important things I recommend is physical therapy. And regardless of the condition that you have, physical therapy is an important part of recovering from anything, essentially. But timing of physical therapy is important. And what I typically do is recommend not doing physical therapy either right after an injury or right after onset of symptoms or the worst of the symptoms. Because what physical therapy does is strengthen your muscles, stretches your muscles, but depending on the timing could increase the inflammation and make your pain worse. So I typically wait until after a period of immobilization, which is used to decrease inflammation. And like I mentioned before, you typically are a little stiff, but then once your inflammation is calmed down, the therapy is there to build you back up again, strength, range of motion, etc. And the physical therapists nowadays have a bunch of different modalities that they can use, like dry needling, shockwave therapy, ultrasound, all these different things to really help you. So it's an important part of what I recommend. And at the end of physical therapy, when you're kind of getting over whatever it is that's bothering you, what they recommend and what I suggest is develop a home exercise program, because a lot of what physical therapy does for you is preventative. So in order to prevent these things from coming back, if you maintain the exercises, the routine, the stretches that they recommend, that's your best way and best bet of preventing it from coming back again. A lot of patients kind of stop doing the therapy once their symptoms are gone, and it tends to recur. So it's an important thing to continue doing that even after your symptoms are gone. And the last point I have here is preventative stretching, and I recommend incorporating that into your daily routine, specifically stretching your calf muscle. And the picture on the right demonstrates what's called a runner's stretch, where the back knee is straight, the front knee is bent, and this person here is stretching their right calf. And you lean forward to really get that ankle up as far as you can to stretch that calf muscle. There's a lot of conditions in the foot and ankle that come on or can get worse with a tight calf muscle. And adding this to your daily routine, again, even if you don't have any symptoms, more preventative measure is a good thing to consider doing. It's an easy thing to do. Again, a minute or two in the morning, a minute or two at night can really make a difference long term. So that's what I suggest to most patients. So I went over kind of a broad swath of non-surgical treatments. The last little bit of my lecture is talking about operative treatment. And in my practice, operative treatment is reserved for patients that have failed non-surgical management, meaning they've tried all of these things to try to get better on their own, immobilization, therapy, rest, anti-inflammatories, etc., and it's still impacting their life negatively. That's when you want to consider operative intervention. So it's not common. Most people tend to get better with non-surgical, but there's a reason I still have a job, and it's because surgery is needed for some people. So operative treatments for arthritis care, again, one of the most common things I do. And depending on the joint involved, we can either replace the joint or fuse the joint. And most joints in the foot tend to be fused, and in the ankle, I'm a big advocate for ankle replacement. And it's not just the joint involved, depends on the severity of the arthritis, some patient factors as well. But that's the mainstay of treatment for arthritis care, is either fusing the joint, replacing the joint, again, depending on the joint and the location. You can see in the top right, that's someone who has significant arthritis of their ankle on the left side. And then on the right, that's after an ankle replacement. And that white are metal caps that you put where the arthritis was and the cartilage was. And in between this white metal, you can't see it on the x-ray here, is a plastic insert, which acts as replacement cartilage that allows your ankle to move normally. On the bottom right, I have a picture of someone with really severe great toe arthritis. Where my cursor is where the arthritis is. You can see bone on bone there. And this is after a joint fusion of the big toe, where you remove the cartilage ends, you remove the sclerotic, not great bone, and you attach the bones together and get them to fuse and hold together with plates and screws. With arthritis, or depending on the severity of arthritis, when they're milder, you can actually consider arthroscopic surgery, which is through small incisions, you take a camera, stick it into the joint, and through another small incision, can shave, debride, clean up small, minor cartilage issues. And you can do that from the front of the ankle, which is here, or even from the back of the ankle, which is for certain conditions. So that's one of the many minimally invasive things that I can help you with and do to manage arthritis type care. Another common surgery that I do is managing peroneal tendonitis. And if you remember in my talk earlier, I mentioned that tendonitis can often be associated with tears or instability. And if the tendonitis continues to progress, again, despite immobilization, therapy, anti-inflammatories, it almost certainly is associated with a tear that needs to be repaired. And on that bottom left, you can see an example of a tear coming right through the middle of that tendon. And the reason it's bothersome is every time you move that tendon, it glides, that tear catches on the bone, the adjacent soft tissue, and causes irritation. And the way you repair that is you stitch it back up. And you can see right here in the middle an example of repairing a tendon. On the far right, you see here, that's your fibula bone here. And normally underneath that bone is where your tendons live. And depending on the severity, the tendons can actually pop out of that groove and dislocate. And the way you go about repairing that is you essentially recreate a sheath of the tendon that was either damaged due to injury or degenerative conditions. You go in there and physically recreate a sheath to keep those tendons locked where they are. So again, examples of how you address tendonitis, specifically perineal tendonitis. In the same vein, with Achilles tendonitis, you have the same issue. You get partial tears in the Achilles tendon, it causes degeneration, and there's oftentimes some bony overgrowth or bone spurs that developed in your heel bone that need to be addressed. You can do it minimally invasive or open, and on the picture on the far left and the far right are examples of minimally invasive tendon repair surgery or tendon debridement surgery. On the bottom left is an example of a tendon debridement surgery where we make an incision in the middle of the tendon. We open up the tendon, leaving the attachments in place. We clean up the degenerative parts of the tendon. We remove any impinging bone spurs or signs of degeneration, and then anchor the tendon back down using suture anchors that attach into your calcaneus bone further down, here and here. On the far right is an example of a minimally invasive Achilles repair surgery, or the PAR system, percutaneous Achilles repair system, where you make a small incision right here in the middle of the tendon, and through percutaneous poke holes, you're able to grab the tendon, pull it down, and anchor it into the bone with minimal incisions. So it's not just for cosmesis, you want a smaller scar, but also the smaller the incision, the less chance of a wound healing issue or infection, and incisions that are smaller typically tend to heal a little bit easier, a little more reliably. And if all else fails, if some patients in some conditions, you can't do minimally invasive surgery safely, you have to make a big incision. That's what that middle incision, or middle picture shows. It's a large incision to repair two ends of a ruptured Achilles tendon. When it comes to bunion surgery, just like most things, there's also minimally invasive options that are possible. I'll show you on the bottom left is an example of the incisions of a minimally invasive bunion surgery. You can see 1, 2, 3, 4, maybe 1 or 2 centimeter size incisions that through those you're able to perform the necessary bone cuts and screw placement needed to correct a bunion. And that picture on the bottom left is what is an example of the surgery on the x-rays of the bottom right, where you can see this patient had a pretty significant bunion with this angulation of the big toe, but through that minimally invasive surgery, you're able to perform a bone cut, insert 2 screws, and also perform a bone cut of the big toe further down to bring that toe over. And you can see how the overall alignment of that toe is much straighter. The top right is an example of a more open option where instead of doing these percutaneous incisions, you make a still relatively small incision on the inside of the big toe here. Through that incision, make the bone cuts, place a single screw. Here I use a staple to correct that. And you can see how the foot, which had a bigger bunion deformity, is now straight after correction. Patient also had a bunionette, which is a bunion on the other side of the foot, the 5th metatarsal, that was also corrected here with a percutaneous pin. Another common surgery that I do is for recurrent ankle sprains. So most ankle sprains get better on their own with immobilization, physical therapy, etc. But there's a handful of patients where their ankle sprain that they just had was the straw that broke the camel's back. Essentially, with every sprain, the ligament stretches and stretches and stretches and gets to a point where it's no longer providing the restraint you need to keep a stable ankle. So if it comes to that and non-operative treatment fails, then we talk about doing a ligament reconstruction, where essentially either for a torn tendon, or a torn ligament or a stretched ligament, you retighten it with sutures. And what I use is suture anchors that you place into the bone that have great fixation. From these anchors come out sutures where you grab the ligament that's affected and retighten it back down to bone. It's called a Brostrom ligament reconstruction, one of the more common things that we do, and very reliable, and gets patients back to the activity that they were at before pretty quickly. Lastly, I want to touch on fracture surgery, which is one of the things I enjoy doing and one of the more common things that I have to do. And you can see here, these are all different types of fractures affecting different bones and different types of constructs with plates and screws and hardware to get the bones lined up again. Now, not all fractures need surgery, and a lot of times fractures more commonly end up not needing surgery and they heal up on their own. But for displaced fractures where the bones are in different zip codes, or fractures that affect the joint surfaces, it's important to realign the bones or the joints to make sure you provide the right anatomy for the patient to get back to doing what they want to do. Because any subtle deviation in anatomy, even a few millimeters of displacement, particularly at a joint, can lead you to arthritis. Because different parts of your cartilage and joint will be experiencing forces that they're not used to if the bones don't heal properly. So it's an important part of what I do is to restore native anatomy, and that's what fracture surgery does. And this up here is a fracture of the ankle, of the talus bone. Down here is a fracture of the calcaneus or the heel bone. This is what we call a trimalleolar ankle fracture, involvement of 3 parts of the ankle. This is a screw fixation of a Jones fracture, and here is the fixation of a Lisfranc fracture. So a lot of different injuries can occur in the foot, and if it comes to surgery, there are ways to fix it. So I want to thank everyone for, again, spending time listening to me talk about easing foot and ankle pain. Hopefully that was educational, informative, and gives you at least a stepping stone or a baseline to have a little more informed thought about what might be going on in your foot and ankle. Now I'll open up to Wendy to ask any questions from the audience.
Thank you so much, Doctor. We do have a few questions, and I think a few more will roll in here. So I'll start with the first one. It's dealing with compression. There were a couple of compression questions. And the first one is, by compression, do you mean like an ACE bandage?
Yes, so there are several different ways to provide compression, one of them being ACE bandages. And ACE bandage is nice that you can dial in exactly how much compression feels comfortable. You essentially want it to feel snug, but not too tight. There are other ways to do that, and that's with compression socks, and they sell compression socks that go up to your ankle, up to your knee, or even up to your thigh, and they have different gauges as well and different levels of pressure. So those you can't really dial in exactly how much compression. They're kind of pre-made that way. But yes, ACE wrap is a good way to do it. That's what I recommend for a lot of people because you can adjust it as needed.
Exactly. Yeah, I worry about using ACE bandage. Can it lead to just cut off blood circulation and cause a lot of problems if it's too tight?
Theoretically, yes, it can, but you will know if that's the case. And what I mean by that is it will be very uncomfortable if your ACE wrap is that tight that it cuts off blood circulation. So as long as you're in a state where it doesn't hurt that bad, it just feels snug, that's usually enough compression. If it's compressed to a point where it's uncomfortable, that's when it's probably too tight, and that's when I'd suggest loosening up the ACE bandage. It's pretty hard to cut off circulation. You have to wrap it really, really tight, and again, you will know it'll be very, very uncomfortable if it's that tight.
Yeah, would your toes turn blue and that kind of thing?
Yeah, that's probably too late if it's that far. So it's more so just discomfort and the amount of pressure, and that's why I suggest loosening up if that's the case.
Right. Is the cost of the boots and the braces and the pads usually covered by insurance?
So yes, for the boot and the brace, and oftentimes for medical equipment, boot and brace are covered to some extent by insurance. Now, every insurance is slightly different, and depending on your insurance, they may equate a boot and a brace to the same thing, or if you've gotten a boot or a brace charged through insurance within the last 2 or 3 years, they may say you already have one, you can't get another one. So there's caveats all over the place, but for boot and braces, yes. If it's your first time, it's covered to some extent, and it just depends on the plan you have. What I tell patients who have gotten a boot recently and misplaced it, can't find it, or they were given a boot when they went to an urgent care, but it wasn't the right kind, there are places to get a cheaper boot option online or at a store in person. So there's ways to find alternative options that you don't have to go through insurance that are still relatively affordable. But yes, to answer your question in general, boot and braces are. Some of the smaller things like metatarsal pads, heel cups, etc., not covered by insurance. Those are smaller items, but boot and braces are.
Where do you purchase those pads?
So we sell them in our clinic, so if you're seeing me, we can definitely provide you with those. But in general, you can get them at most pharmacies in the foot care aisle or on Amazon. Nowadays, you can get most things on Amazon, and what I show patients in the clinic room is that if they're interested in going home and getting it themselves, you do a quick Google search, quick Amazon search, you can find those things on there.
I see. Guest says, I'm having quite bad pain in the ball of my foot and second toe. What do you think is causing this?
So that is, again, not knowing more than that, that might be what we call metatarsalgia, which is if you have either arthritis or a bunion in your first toe, that actually causes more pressure to be put on your second toe. And plantarly, if you're on the bottom of your foot, on the ball of your foot, it's underneath your second toe, it's probably because you're putting extra force there. And there's a couple things you can try, one of which are the calf stretches, which I suggest because if you have a tight calf, your foot ever so slightly is pointed down a little bit more. So the front of your foot gets a little force. So regular calf stretches can offload that. But also those metatarsal pads I mentioned before, that's a good first line solution for pain in the ball of your foot. And the one thing that I make sure to emphasize if you're considering getting a metatarsal pad is not putting the pad where it hurts, put it just above where it hurts, further towards the heel, because if you put it where it hurts, then it's only going to put more pressure on that area and cause you more pain. You want to put it just above it, closer towards the heel from where the pain is, so that when you take a step, your foot hits that pad, it elevates your toes and offloads them. So hopefully that helps going forward for you.
Great, thank you. How can you tell if you have a partial tearing of a tendon?
So there's no way to know except for really getting an MRI. If it was fully ruptured, you would certainly know because you wouldn't be able to move your foot in that direction depending on what tendon is injured. But whether it's just inflammation or a partial tear, there's no great way of knowing. And at least in the early stages of treatment, in my hands and my treatment strategy, there's no difference because essentially we would do the same things whether it was just inflamed or partially torn, and that would be anti-inflammatories, rest, ice, compression, elevation, some form of mobilization, and therapy. It's only after all those things fail, if you're still having persistent symptoms, that we would consider getting an MRI. But in the beginning, the difference between a partial tear or just inflammation, no real difference in terms of clinical treatment strategy.
Exactly. This guest asks, are some of the non-surgical things you mentioned helpful for hallux rigidus of the big toe?
Yes, so hallux rigidus is arthritis of the big toe. And the slide about supportive shoes and supportive orthotics is really helpful. In particular, the thick-soled shoes and the rigid shoes are very beneficial for hallux rigidus or big toe arthritis because the point I made before about having less bend and less flexibility in your shoe means less motion across the big toe. And what usually hurts in hallux rigidus or big toe arthritis is your toe being bent up at the very top. And if you have a stiff shoe, there's less bend across the toe. That helps a lot. So it's the mainstay of treatment for early big toe arthritis is supportive shoes and orthotics to have a rigid sole to it.
Do weak medial glutes contribute to a case of plantar fasciitis?
Could you say that one more time?
Do weak medial glutes contribute to a case of plantar fasciitis? They've spelled it MEDIALGLUTES.
Okay. If by glutes you're referring to your glute muscles and your upper thigh and your butt, then typically I wouldn't say there's a direct relation to it, with a caveat, meaning that your whole musculoskeletal system are all kind of interconnected. So if you have maybe tight gluteus muscles, that may mean your whole backside of your leg is tight. That includes your hamstrings and your calf muscles. So that could be an indication that you have more tight calf muscles, which in turn there's a more direct correlation to developing plantar fasciitis. So while there's no, I wouldn't say direct relationship, there certainly might be an indirect relationship and that certainly could be the case.
Thank you. What is the typical recovery time for ankle replacement and perhaps some of the other surgeries you spoke about?
So for most surgeries, there's a short period of non-weight bearing. That's surgeries in the ankle or in the hind foot, middle of the foot. It can be anywhere from 2 weeks of non-weight bearing to as much as 6 weeks, just depends on the surgery. For ankle replacement specifically, for my protocol, it's about 2 weeks of non-weight bearing, maybe 3, and then progressive increased weight bearing. So you start with what we call toe touch weight bearing, where you rest the toe on the ground, then you progress to about 50% weight bearing, and then you progress to full weight bearing, and that's over the course of several weeks. The reason is, at least for total ankle replacements, is that there's some amount of weight bearing in the early stages that's actually beneficial for it. And the compression of your ankle actually helps the bone incorporate into the prosthesis. So it's a delicate balance of letting things heal and also allowing for appropriate weight bearing to happen. For toe surgeries, I actually let you walk on it immediately. And that's because the post-op shoe that I showed you before is really a really good surface to allow you to bear weight with protecting the toes. So for most toe surgeries, you're walking on it pretty immediately. For other surgeries in the foot and ankle, short period of non-weight bearing, followed by progressive increased weight bearing.
Thank you. How often should orthotics be replaced?
So that's a very good question. There's no time, there's no expiration date necessarily. It's more about the support you feel and the condition of it. So for people that are really heavy on their orthotics, they start to wear out, and particularly in the heel in the middle of the foot, where there was arch support, there no longer is. And you can see if you take the orthotic out, take a look at it, there's wear and tear, and if you look at it from the back, you can see the arch is not as high anymore. So signs like that. And in general, if you don't have the same pain relief or support or symptom relief that you were having before, that's a sign that maybe the orthotics are wearing out. So while there's no set expiration, it's all that kind of depends on your activity level. And if you're someone who's very active on it, that could be as soon as 9 months to a year. Someone who's less active on it, it could last you for 2, 3, 4 years pretty well.
Is there any treatment for chronic non-arthritic lateral ankle swelling due to inversion sprains?
Yes. So it sounds like this is someone who's had recurrent ankle sprains and keeps spraining their ankle. And the first line treatment for that is, if you haven't tried it, is some type of bracing and therapy. But for a lot of folks, there comes a point where the ligaments keep getting injured to a point where they're no longer strong enough to support the ankle. And that's when you want to consider surgery. Because what happens if you don't do surgery and you keep spraining your ankle, with every successive sprain, your ankle's shifting and moving more than it normally should. And there may come a point where that shifting and moving results in cartilage injury or cartilage wear down over time, which could result eventually in early arthritis. So if you're someone who continues to have ankle sprains, even with low impact activity, then you may want to consider getting it surgically tightened and repaired, because you may be creating more downstream effects down the line for you.
Is it true that bone spurs on your heel are common with plantar fasciitis? Is that really the thing that's causing all the pain in your heel? And can you talk about bone spur surgery?
Yes, so for plantar fasciitis specifically, it's a very common finding on an x-ray to have a bone spur on the bottom of your heel, right where or adjacent to where your plantar fascia starts. And what I tell patients is that it's not actually the bone spur itself that's causing the symptoms. The bone spur is more of a sign or a symptom itself of plantar fasciitis. The bone spurs take years to develop, and for most folks, they don't have years of plantar fasciitis. It's more of a several-month inflammation that typically resolves over time. So you've been living, or patients live with the bone spur for a long time, and they have no pain or symptoms. So it's not necessarily the spur itself, it's what the spur means, or what the spur infers is that there's a inflammation and pulling of the plantar fascia around that area, and your body reacts to it by making a spur. So when you come to talk about bone spur surgery, specifically for plantar fasciitis, what that is removing the spur, but you're often also releasing the origin of the plantar fascia. You're essentially cutting it. And that's what the treatments for plantar fasciitis surgically is. So by removing the spur, you're also cutting the plantar fascia itself, thereby relieving the stretching and the inflammation of it. So what I ascribe to is that the spur itself is not causing the symptom. It's more of a symptom of the plantar fasciitis itself.
I see. Can you see the difference between OA and RA on x-rays? Operative arthritis or rheumatoid arthritis?
Right, so OA is osteoarthritis. That's the more generic, common wear and tear arthritis. Rheumatoid arthritis is one of those autoimmune conditions. And for certain joints, yes, you can tell the difference. But more globally, if you have an x-ray of a foot or an ankle, if you have rheumatoid arthritis, you almost certainly have arthritis in multiple joints because it's a autoimmune condition through your blood where your antibodies attack your own cells. And so you get arthritis in multiple spots. And especially in the foot, there's some characteristic deformities. Your toes kind of deviate laterally. They become curled and stiff. And so you get multiple joints involved. With osteoarthritis, you can have multiple joints, but not all the foot. It's usually a handful of joints that are involved, either because of the way you walk or a previous injury, but it's usually one or two joints, maybe a handful in OA. But in RA, it's a lot of joints. It's not just the foot and ankle. It can be the shoulder, the hip, the knee. Oftentimes the other foot and ankle is also involved. So it's more about the number of joints involved, typically, and that's how you distinguish one or the other.
Thank you. This guest says that the front of their ankle is numb and it itches. Also, the arch can be numb, and walking makes all of that worse. They've been told that they might have Morton's neuroma. All right, do you have comments about that?
Yeah, so
especially numbness and itching.
A Morton's neuroma is a growth or an inflammation of the nerve closer to your toes. So it can cause numbness in the bottom of your foot, but it usually just involves the toes. The numbness in the front of the ankle or in the arch of the foot, those are two different nerves that are involved in terms of how your sensation goes in your foot and ankle. So potentially there may be some element of a nerve issue higher up in your leg or even in your lower back. And a lot of spine issues and nerve issues coming from the spine can result in foot and ankle symptoms. And depending on the distribution of the symptoms and the nerves and where you're having this numbness, it can actually be a spine issue or a higher up issue. But a Morton's neuroma typically involves the toes, not necessarily the ankle or the arch.
Thank you. Would the pads help with toe arthritis?
So yes, they can. So if you have arthritis in the toes, the knuckle of the toe or further down, those metatarsal pads can help because it does offload the toes with every step you take. So that's not a bad thing to do for lesser toe arthritis. If you're talking about big toe arthritis, it's the stiffer shoes and the stiffer orthotics that help more than the metatarsal pads do.
Thank you. What is a high ankle sprain?
So a high ankle sprain involves a sprain of ligaments in your ankle that are slightly different than what you get in a common ankle sprain. So the ankle sprain ligaments in a common ankle sprain are between your fibula and your talus and your fibula and your calcaneus, essentially down by your foot. A high ankle sprain involves the connection between your tibia and your fibula. It's a slightly different mechanism. It's more of an external rotation force that causes it, but it's a different set of ligaments that are involved. And the treatment for both, at least initially, roughly the same, meaning a period of immobilization followed by therapy. But the treatments for them, if it needs surgery long-term, slightly different. It involves restoring the connection between different bones, essentially.
Please comment on zero-raised shoes for Morton's neuroma, like limbs and ultra shoes.
So I'm not super familiar with those shoes, but my assumption or my guess is that these are kind of low profile, not as thick soled shoes, if I'm reading this correctly. So for Bunion Roma in particular, depending on the patient, depending on the location of it, I think in general, it may aggravate it and inflame it. And for the reasons I discussed before, if you're not having too much support, similar to walking barefoot, there's just more pressure that goes across the bottom of your foot where the Bunion Roma could be, and it could subsequently get more inflamed. So just like for other conditions with Bunion Roma, having more support typically works. And the reason I say typically is that every patient's a little bit different, and everyone's body is different, anatomy is different, and getting something over the counter may not fit that person in particular. So while for some people, the low profile shoes make a difference, on average, in general, the thicker the sole, more support usually works well.
Thank you. This guest asked, do you see hammer toes? Do you treat hammer toes? And is it important to fix them?
So
and
yes.
What is a hammer toe?
So a hammer toe is a curling of your lesser toes, and they can start out as being flexible, meaning they get curled and you can straighten them out, but over time they can get rigid and stuck like that. And yes, it's one of the surgeries that I do, and I do that relatively frequently. And hammer toes themselves, if they don't cause pain, I would recommend not doing surgery for it. And in general, foot and ankle conditions, not a big fan of cosmetic foot and ankle surgery. If you're having pain and it causes functional limitation, then absolutely, I think surgery is a good indication for that. And just like with hammer toes, a lot of people have them and they're not symptomatic. I'd say leave them alone. There's things like toe spacers or different types of over-the-counter splints that you can put to tape the toe down to keep it straight. But what can happen with hammer toes, especially in kind of narrower toed shoes, the top of the toe box can rub against the top of the hammer toe, causing irritation and pain, and sometimes even a wound develops. And if any of those things are happening, then I would suggest surgery for it. And the surgery is essentially fusing the toe straight. You still have motion in this joint here, but the tips of the toes stay straight. And people with really severe hammer toes, they can't really move them on their own because they're so rigidly fixed. So what I tell patients is that you're trading in a rigid curled toe for a rigid straight toe. And what that straight toe does is prevent the rubbing in the shoe, which is typically what causes patients most symptoms with hammer toes.
Thank you. I'm going to try to pronounce this right. Is peroneal arthritis a fallen arch? And is there a chance a fallen arch will heal permanently?
Can you say that one more time? Sorry.
Yeah. Is peroneal arthritis, P-E-R-N-E-A-L, arthritis, a fallen arch? And is there a chance a fallen arch will heal permanently?
Okay. So the peroneal arthritis, I think we're getting two things confused or mixed up. Peroneal tendons are what run on the outside of our ankles, and tendonitis of those is a common condition. So it's not quite arthritis, it's tendonitis. But for a fallen arch or a flat foot, that's actually tendonitis of another tendon on the other side of your ankle. It's called your posterior tibial tendon, which is on the inside or medial part of your ankle. And tendonitis to that or tears in that can cause a fallen arch or a flat foot. Early stages of that can certainly be fixed with therapy and bracing. But by fixed, I mean the arch itself usually does not restore its arch again. But the pain resulting from it can be managed with non-surgical treatment like bracing, orthotics, and therapy. The arch itself, the only way to really restore it is a surgery. But if you're not in pain, again, I would not suggest getting the arch fixed because surgery, while it's great for some conditions, if it doesn't go well, it can cause pain. So if you're having pain with a fallen arch, then certainly surgery will help it. But the goal of most of these non-operative treatments is to remove the inflammation and pain, but some of the effects that have already happened from the condition, like a fallen arch, would not be fixed non-surgically.
Right. My dad's always been told he was born flat-footed.
Yeah, and that's a very common thing. About 25% of the adult population have flat feet, and the majority of them are asymptomatic. And a lot of people are born that way. And for the same thing, some people come in saying they have flat feet, or their son or their daughter have flat feet, and they're worried about what that does. And I tell them, as long as they're in pain or not in pain and they're doing everything they want to do, all I'd recommend is orthotics and supportive shoes, and hopefully prevent something from happening down the line. But I don't recommend doing surgery on something like that that's not painful. There are plenty of things that can cause pain. Surgery is one of them. So as long as you're not in pain, I'd suggest keep living your life.
One thing we didn't talk about, how do you address ingrown toenail that continues to cause pain for months?
Yeah, so that's a fair question. That's not something I typically see in my practice. That's something I usually refer to other providers. But what that usually involves is, if it's not getting better despite shaving it down or going to like a pedicurist and really getting underneath it, it actually involves numbing up your toe and cutting out the nail. And that's what it comes down to, is you have to, this is a procedure, even kind of a minor surgery, where you numb it up. You have to remove the toe and really get deep inside it to completely remove it, to allow a new toe to grow, or new toenail to grow back in. So if it's really severe and potentially causing an infection, that's the treatment for it. But again, it's not something I typically do.
Yeah, here we have time for a few more questions. So I'm going to kind of combine two that are sort of similar in terms of, how do you know when it's time to quit using anti-inflammatories and have surgery? And another similar question is, there's arthritis in their ankle, physical therapy is not helping much. How do you know when it is time to have an ankle replacement?
Yeah.
So is it just when you can't take it anymore?
Essentially. A lot of orthopedic conditions, most of them are not life-threatening. Ultimately, it comes down to you as the patient, and you have to kind of do the math in your head. Is the impact on your quality of life from your arthritis or your condition bad enough to where you're willing to accept the risks of surgery? And for a lot of patients, that's when they can't go on walks anymore, they can't spend time with their family, they can't go hiking. You usually end up limiting your activities with these arthritic conditions, and there's one activity or a handful of activities that you can't do anymore. That's the straw that broke the camel's back, and you're like, you know what, I'm more limited, I'm not enjoying my life right now, I'm willing to accept potential risks of surgery to make my life better. And that's only something you can answer, and me as a surgeon, I can kind of guide you and give you all the information you need, but it's something that only you can get to. And that question about NSAIDs, it's something similar. It's that if you can live a tolerable life only by taking NSAIDs every day, there's going to be a downside to that eventually. And if a short period of time, 3 weeks, 4 weeks, usually not enough to cause those downsides, but if you're taking it months on end, certainly that if you're taking oral medications, it can tear up your gut. And oral or topical, it can affect your kidneys too. And they can cause kidney issues and all sorts of things. So there's a point of diminishing returns from taking a lot of NSAIDs over time, and there's no right answer, but if you're someone who's been taking it for months on end regularly, it's probably a good idea to stop, because it's going to cause issues down the line for you in other parts of your body.
Absolutely. Thank you. Let's see, there are a couple of others I really want to get to here. Guest says, I understand that there's a nerve that travels down the leg that wraps around the ankle and can cause pain in the shin and the back of the leg. What can be done for this?
So that's essentially right, that there is a nerve that runs down the back and can cause issues in the foot or ankle. It's a difficult question to answer, only because it depends on where the issue is. Because nerve pain in your shins or in your leg from that nerve could be happening up in your spine, in your back. A pinched nerve in your back can cause focal pain in different spots of your leg. Or it could be in a trapped nerve at your knee or at your ankle, or even your foot. And if there's something in those areas that's putting pressure on the nerve, decompressing that nerve by relieving pressure can help the symptoms too. So it's tough to say exactly what it might be causing it, but it's dependent on the cause of the nerve irritation and inflammation, and that tells you what kind of treatment you need. So it's not quite straightforward, but there's multiple things that could be done for it, depending on where the injury is.
Do you treat peripheral neuropathy? Neuropathy?
Neuropathy, sure. So not directly. And what I mean by that is peripheral neuropathy is degeneration or injury to the nerves starting in your toes and your feet, and it kind of slowly works your way up. And that usually is difficult to treat. With a surgery or with anything, it's really difficult to manage. And it's usually a side effect of either someone who has bad diabetes or has taken medications that's resulted in nerve injury. Once the process has started, it's hard to prevent it or grow the nerves back. But there are things that happen in your foot and ankle due to peripheral neuropathy, and those are the things I treat. So with the diminished sensation throughout your foot, you can develop deformities in the foot because your body isn't responding to pressure the same way because your nerves are injured. You can develop wounds in the foot. So there's downstream effects of having peripheral neuropathy that I'd certainly manage all the time. But the peripheral neuropathy itself is not something that I manage or frankly can be managed, just because it's something that's difficult to treat.
Thank you. Can you talk about quickly tarsal tunnel? What is it and how to treat it?
So in the inside of your foot, it's a nerve condition where there's a tunnel in the foot that your nerve runs through. And if you have compression of that nerve in that area, it can cause pain, numbness, tingling all throughout your foot, particularly in the bottom of your foot. So a tarsal tunnel release is a surgery where you open that area up and decompress the nerve, and give it room to breathe, get it back to where it was before. So it certainly exists, and there can be different lesions within that tunnel causing compression in the nerve. So surgery to correct that and remove those lesions, it can be beneficial in patients that have those symptoms.